Hey everyone, let's dive right into today's explainer. We've tailored this one specifically for you, the postgraduate gynecology students out there. Today, we're focusing on a genuinely novel, highly effective surgical technique for middle pelvic prolapse, laparoscopic uterosacral ligament consolidation and fixation. As future pelvic surgeons, you already know that finding an anatomically sound, long-lasting solution to prolapse is literally one of our biggest challenges. Well, we might just have a game changer on our hands. Here is our roadmap for today. We're going to cover the complications of current methods, introduce the new approach, go over patient selection and pre-op, walk through the step-by-step surgical technique, discuss post-op management, and wrap up with the core innovations and takeaways. All right, let's kick things off with Section 1, the clinical dilemma. Why do we even need a new approach to middle pelvic prolapse? Well, we need a new approach because the current methods kind of fall short. We all know the standard playbook, right? But sacrocolpopexy, sacrospinous ligament fixation, and high uterosacral ligament suspension all carry significant, sometimes debilitating risks. With sacrocolpopexy, you're constantly worrying about mesh exposure and intestinal obstruction. SSLF brings the absolute dread of rectal injury or sciatic nerve compression syndrome. And HUS, we have all sweat over potential ureteral injuries. The harsh reality is that these complications often require reoperation. We absolutely need a better way. That brings us to Section 2. Let's introduce this new approach through the lens of a real-world patient case, because context is everything. Let's review these baseline numbers, which beautifully illustrate exactly who benefits from this surgery. This is a 68-year-old patient with a 20-year history of vaginal prolapse that got significantly worse over the past year. Her POPQ scores upon admission are severe across the board. I mean, a C-score of +8 and a D of +5? You guys know that points to massive apical descent. This is a complex, long-standing case, exactly the kind that really tests the limits of our traditional repairs. Moving right along to Section 3, patient selection and pre-op clinical prerequisites. So before you even think about scrubbing in, you have to follow 3 strict pre-op steps. First, your baseline for eligibility is a POQ score of stage 2 or greater. Second, you've got to exclude patients with a chronic cough or any pelvic malignancies. Basic surgical principles definitely apply here. Finally, tissue preparation is totally key. A 3D conventional vaginal scrub is performed, and for postmenopausal women with vaginal mucosal atrophy, you apply topical estrogen ointment a full week prior to surgery. In fact, our case study patient presented with a mucosal ulcer, and they literally had to delay the surgery until it fully healed. You just can't compromise on tissue health. Okay, here's the really fun part. Section 4, our step-by-step anatomical walkthrough. We begin, as always, by managing our danger zones. Step 1 is confirming the ureter's position by cutting the pelvic peritoneum to establish a ureteral tunnel. Once you're secure there, you sharply separate the connective tissue of the rectolateral fossa to safely expose the medial sacrospinous ligament. And here's a neat trick. An assistant actually touches the sciatic spine from the vagina to help you locate this. You gently pull the sacrospinous ligament to confirm, exposing the complex right near the sacrum attachment. Next, you bring in the ultrasonic knife. By carefully cutting the lateral serous layer of the uterosacral ligament, you can safely push the ureter laterally, completely out of harm's way. This meticulous dissection exposes the entire lateral section of the uterosacral ligament, totally prepping it for the consolidation phase. Now, if you only remember one thing from this explainer, make it this: the 3-step suture technique. This forms the biomechanical climax of the entire procedure. You aren't just throwing stitches here, you're structurally recreating the pelvic floor. It goes fixation, shortening, and vaginal vault fixation. Let's break these down. In Step 1, fixation, you take a non-absorbable suture and grab a precise 3 to 5 millimeter bite of the sacrospinous ligament and coccygeus muscle complex near the sacrum. You pull it for adequate tension and knot it directly to the sacral part of the uterosacral ligament. You're basically dropping your anchor here. Moving to Step 2, strengthening. You use that exact same stitch to take 2 to 3 bites of the middle part of the uterosacral ligament. Tying this knot definitively shortens and strengthens the ligament. It directly addresses the exact laxity that caused the prolapse in the first place. For the third and final step, your assistant elevates the vaginal vault with a gauze ball. You then pass the suture through the neck of the uterosacral ligament and the entire top layer of the closed vagina. But crucially, and this is a big one, you must not penetrate the mucous membrane. Tightening this suture pulls the vaginal tip roughly 2 centimeters above the sciatic spine before you tie that final knot. Boom! You've just completed the 3-step consolidation on one side. After you perform those exact same steps on the right side, you do a quick check to confirm the vaginal vault has a healthy range of motion, about 1 to 2 centimeters. Then you utilize bipolar electrocoagulation for hemostasis, and finally close the peritoneum with an absorption suture. You're left with a clean, beautifully restored pelvis. Let's look at Section 5, post-operative management. Because as we know, a beautiful surgery can easily be ruined by poor post-op care. Immediate management is pretty straightforward, a continuous catheter for 5 to 6 days alongside standard antibiotics. Again, topical estrogen is used for menopausal patients to help that tissue heal. Once the catheter is out, you check residual urine volume. But the real proof of success is in the long-term follow-up. We're talking checks at 1, 3, 6, 9, and 12 months to document subjective symptom relief, making sure the patient feels no bulging, and objective cures, aiming for a POPQ stage 0. For a complex 20-year prolapse case, hitting a true stage 0 cure is an absolutely incredible result. Let's wrap things up with Section 6, core innovations and takeaways. Why does this approach actually matter for your future practice? This technique is brilliant for 4 huge reasons. First, it changes the fixation point back to the true physiological attachment point. Second, by using the existing uterosacral ligament to strengthen the middle section, it aligns perfectly with the body's own concept of self-repair. Third, that 3-step suture technique is incredibly stable. It effectively eliminates the problem of ligament avulsion. Get this, in 50 surgeries, the authors reported 0 cases of relapse. 0! Finally, because there's no change in the vaginal axial direction, it massively reduces the incidence of anterior vaginal wall prolapse and can actually preserve or even improve post-operative sexual life. So, as you head into your next surgical rotation, I really want you to think about this. How could adopting this anatomically sound 3-step technique radically improve your own patient outcomes? Could this become the new gold standard that you bring to your future practice? Keep pushing the boundaries of pelvic medicine, guys. Thanks for joining me on this explainer.